All attendees are in listen-only mode.
Hello, everybody. This is John Muscaderi, the Scientific Director for the Canadian Frailty Network, and welcome to today's webinar. Today's webinar is on benchmarking end-of-life care practices for elderly people receiving primary care. And this will be presented by Francis Lau from the University of Victoria. I'm just going to open with some introductory comments before I introduce our speaker. This is part of our webinar series, which showcases research supported by the Canadian Frailty Network, which is predominantly on frailty and late life issues. Thus far in 2016, we have had 20 webinars, and we'll continue with the bi-weekly webinars for the majority of 2016. And just to remind you, all the webinar, the recorded webinar and slides are posted on our website, and the website address is listed on the screen. Just a quick update as to what's happening at the Canadian Frailty Network. Our 2016 Summer Student Awards, we had originally advertised that we were going to give out 10, but we've been able to double the number of awards to 20. The application window is closed, and the announcement of the successful applicants will be made later on this month. We had a record number of applications for this, and this was one of the reasons why we've doubled the number of awards. Our new one-year fellowships were announced, and these have been posted to the CFN website. Our collaboration with the Canadian Foundation for Healthcare Improvement and to improve elder-friendly hospitals across Canada. We've selected 18 acute care hospitals to participate in this. The hospitals that will participate were announced last week at an announcement at Mount Sinai, which was attended by the Federal Health Minister, Dr. Philpott. And we look forward to continuing that activity over the next year. Our quarterly newsletter will be distributed next week, so be on the lookout for that. The format for these webinars is that we usually have a question and answer period after the presentation. Please submit your questions online during the presentation using the chat function on the webinar, and we will answer as many of the questions as possible at the end of the presentation. And as I said before, the webinar is recorded and available for viewing online within 1 to 2 days. So without further ado, I'd like to present, to introduce our presenter, Dr. Francis Lau. Dr. Lau has a PhD in medical sciences with specialization in medical informatics, and is a professor in the School of Health Information Science at the University of Victoria. And he is a recipient of CHR InfoWay eHealth Chair to examine health information system development deployment in Canada. He has extensive background in business, computing, and medical sciences with 14 years in the health information technology industry, and his research interests include health information system evaluation, clinical vocabularies, and palliative care informatics. At the end of the webinar, we will have a feedback session, so please fill that out. But without further ado, I'll turn it over to Dr. Lau for his presentation. Welcome, Dr. Lau.
Thank you, John, for the introduction, and thank you for attending today's session. I appreciate you taking time out of your busy schedule to attend this particular session. As John alluded to, this particular session is to talk about benchmarking end-of-life care for the elderly in primary care. Keeping in mind this is a knowledge translation project, so it was intended to bring best practices to the point of care as opposed to conducting sort of research in that sense. As you see on this slide at the bottom, this is very much a collaborative partnership project with a number of organizations involved. And these individuals listed here, Doris, Neil, Bruce, Morgan, they're the co-investigators, with Doris being a co-principal investigator on this 3-year project, representing these different organizations. And there's also a project team and a number of individuals involved. So I just want to make sure that you recognize this is very much a team effort. And this is the outline, in that I'm just going to go through some of the information around this project in terms of the objectives and some of the stages that we went through, the methods. And given that this was a 3-year project, I would only be able to present some selective findings and some of the lessons learned, and also some of the next steps that we hope to achieve in the coming year. In terms of the project objectives, the overall objective was that this was a 30-month project, a knowledge translation project to introduce electronic medical record, or EMR, supported best practices in end-of-life care within the primary care setting in British Columbia. The overriding research question still, even though it's a knowledge translation project, we did try to pose a question, and it was whether palliative approach can be integrated into electronic medical records to enhance end-of-life care in ways that are measurable, scalable, and sustainable. And with the palliative approach, it really is a philosophy of palliative care that is trying to incorporate it into the improving the quality of care of individuals that are in with a life-limiting illness, and to try to have that care initiated as early as possible in the trajectory. Some of the specific objectives that we wanted to achieve, I think we can highlight the 2 main ones here. The original objective then was to identify electronic medical record supported tools and requirements, and develop and implement specific EMR tools, and then to evaluate the uptake and impact. So that was very much the original knowledge translation project objective, and there's a number of sort of smaller objectives, but you can bundle them into this particular bullet point. And then later on, towards the final year, we also increased, sort of extended another objective, which is to do with looking at the extent of end-of-life care documentation that was being done in existing electronic medical records, to try to identify some of the gaps, recommendations, and next steps. And in terms of the project stages and methods, we had 5 stages over the course of 3 years. First, we went about conducting an assessment of the current, the way that end-of-life care is currently being provided. So that was done through a combination of environmental scan. We also had some practice peer leaders that help us in terms of identify what they did around that time when the project was being done with respect to their end-of-life care practice and gaps, and whatever needs that they identified for us, especially with respect to electronic medical record usage. Stage 2 then involved the actual development of some specific end-of-life tools within electronic medical records, because we need to develop these tools with specific vendor products. So we went through that stage 2 in terms of developing the actual tools for specific EMR products, which I'll talk about later on. Stage 3 involved the actual dissemination of the tools, because once you've got these tools developed, you need to somehow get it out there to the providers within the primary care setting who are using electronic medical records. Stage 4 then was a stage where we conducted some evaluation of these tools in terms of the uptake and the use, and also trying to identify any issues involved. As I indicated earlier, we also incorporated the stage 5 in the final year of our project. We won't be able to have enough time to talk about that today, but it's essentially around the end-of-life care documentation in existing EMRs. If some of you are interested, I can certainly share that information later on outside of this particular seminar. So next, I just want to spend some time talking about some of the selective findings. And these are the bullets that I will go through in terms of touching on different parts of the study. So first of all, it was about the best practices. We did talk about trying to benchmark best practices. So the best practices that we looked at was very much the British Columbia General Practice Services Committee, or GPSC, practice support program, where they actually had developed what they call an end-of-life learning module. And if you look at this particular learning module, and this is the website where they published the learning modules, I just want to take a moment to sort of go through the GPSC, in that it is a collaborative effort, a partnership between the BC Ministry as well as the Doctors of BC. And with this particular practice support program, it's really to try to help with a professional development through a series of learning modules. If you look at the different types of learning modules on the right-hand side, at the lower bottom right, you see that there's a range of different learning modules. The list that's shown there would be adult mental health, advanced access, office efficiency, and somewhere down there towards the end, there's end of life. And on the left-hand side, you see within these learning modules, what they consist of is that they're small group learning sessions, and then there's in-practice supports, and then there's a peer support network. So it's a series of sort of a learning sessions that would allow the providers out in the field to gain some knowledge and some practice tips in terms of how to enhance their practice. And in this particular instance, we're talking about end-of-life care. So if you look at the middle bottom of the screen in terms of learning modules, you see end-of-life being one of the learning modules. And you see there are algorithms, tools, and resources, and learning sessions. So this is just the next page as you drill down on the end-of-life. In this particular case, the link to the tools and resources, in which you will see there's a set of algorithms and forms and assessment tools, clinical tools. So these are all links that will bring you to a set of tools and resources that you can actually download and use in your practice. And in terms of this page, I just bring you to the page with clinical tools, just to show you some examples of the tools that are available. So you see that there's the transition stages, and there's the advanced care plans, and there's also some scripts that you can use in terms of looking at how to go about engaging the patients in terms of looking at, let's say, ESAS, Edmonton Symptom Assessment System, or a pain and symptom diary, etc. So there are all kinds of tools that you can use in your day-to-day practice. And this is the page that talks about the learning module for the end of life, and you see that with these learning sessions, and because the module actually allows you to bring the providers together in some small group learning sessions. I believe there's about 3 sessions altogether, and it's the total of about 3 days or so sessions, but spread over a number of periods, where you learn about using these tools, learning to assess patients' illness experience, and looking at whether compassionate care benefits and benefits plan would be right for the patients, and learning how to recognize key transitional changes, developing a care plan, etc. So they go through all these different topics. And if you look at this particular learning session 1, you'll in fact be spending your time in small group sessions and also in your sort of a practice session, taking back to your practice, engage in some learning exercises, going through all these different items on this particular list. So it's a very sort of rich knowledge exchange and hands-on practice type of learning sessions that the providers would go through. And this is a very busy diagram, but it gives you the essence of the end-of-life care algorithm that sort of provides the foundation of it. Of course, it's based on the UK gold standard framework, but it's incorporated a lot of the sort of the strategies and a lot of thinking from within the, sort of the BC palliative care community and primary care community in terms of, if you like, operationalizing what that gold standard framework would do. And I know it's a busy diagram, we won't be going through all of it, but generally you can see the different section from the top where you would need to go and identify and create registry, and then you assess the patients, and then you would help manage the patient's transition stages, the 5 stages over the course of their illness. And from there, what I want to point out is that, as I pointed out in stage 1, we were looking at the current best practices and also at the same time trying to identify the needs. And these blue boxes that popped up would be sort of areas where we're expected that some kind of tools would be helpful within the electronic medical record in terms of implementing and operationalizing this algorithm into something that the clinicians can use. So you see there's, you know, registration, assessment, and also in terms of patient summary, care plans, some forms, etc., and reports, etc. So that is sort of the basis in which we went on to create the actual EMR tools. Next, I'm going to go into the functional requirements blueprint. Out of the requirements of the needs that were mentioned by the practice leaders as we sort of worked with them to try to look at how they did their day-to-day end-of-life care practice, we came away with a whole long list of needs, which we then turned into sort of a what we call a blueprint. And this blueprint document, in fact, is about 80-some pages long, and it was actually developed by several clinicians. It was Colin Partridge and Bruce Hobson, their family docs, and then there was also Morgan Price. He's also an academic clinician looking at the use of EMRs from a research evaluation perspective. And then there's Neil Hilliard, who's a palliative care specialist from Fraser Health. So these folks all took part in terms of putting together this particular document. And I should also emphasize this document took on the sort of the style and format of what the practice support program advocates when they develop functional specs for their EMR tool. So we try to be as much as possible to be consistent with what the other folks are working on when they go and try to develop EMR tools. So you see that, you know, there's some general design principles, then there's some design elements in terms of what should be available in terms of the functions and the screens, and then there's the consideration about the workflow, because that's very much important aspect of trying to make use of these tools at the right time when they're delivering the care. Then there's also a set of appendices incorporating some of the data elements and some of the quality indicators and some of the symptom management assessment tools, so that we have a comprehensive document. I should emphasize this document was really only a starting point because we expected fully that over time it will need to be revised and enhanced. So this is an example from that blueprint document, some of the screenshots, and this one in particular has to do with sort of almost like a home page screen that will allow you to get at all the different functions within the EMR. Keeping in mind this is really just a generic design of what are some of the desirable features that should be available within the EMR tools if it's used for end-of-life care. So you see generally there's the ability to register the patient, develop the care plans, provide some kind of summary information, access to forms, and then across the top you see these tabs next to the home tab that will allow you to get into different assessment tools such as palliative performance scale, ESAS, you know, going more into symptom management, etc., etc. And Appendix D also gives you a list of the quality indicators. Now we didn't make up these quality indicators because the end-of-life module from the practice support program came up with a nice set of indicators. There's about 20, 30 some indicators that have already been sort of developed conceptually that would allow one to gauge how well a practice is providing end-of-life care. So we took on these quality indicators to the extent that we can. How do you actually then implement them in the electronic medical record? So we, to do so, what you typically need would be to know what data elements you have. How do you go about identifying the denominators and nominators, and then what do these numbers mean, etc. So we try to give a sense in terms of what the indicators are and what needs to be the denominator and nominator and what they mean, etc. Next, I'll just quickly go over the tools that we have developed. In BC, there's about 6 or 8 different EMR vendors that are being used within the province. And with our effort, we were able to work with sort of 3 EMR products, which is the OSCAR, IntraHealth Profile, and MedAccess. So these were the 3 products that we had some luck in terms of working to incorporate the end-of-life care tools. And here's a snapshot in terms of the OSCAR EMR. Now, OSCAR, as you know, is sort of an open product, open access product, in that there's a OSCAR community in Canada that would allow sort of the users some degree of control input to develop tools and add forms and make suggestions, etc. So it's very much an open product in that regard. And so with that product, we were able to have a developer working within the BC OSCAR community, and also under the direction of Morgan Price, who himself is an OSCAR user, to develop a set of screens, if you like, that follows the OSCAR convention. So these are all e-forms that were developed, and that would allow the users to use them in terms of, in these example screens, to register the patients, look at developing the advanced care plans, have access to documents, etc. And as you can see, what's not shown on the right-hand side of the panel would be sort of the assessment tools and the reports and symptom management tools, etc. So these are just sample screenshots for the OSCAR product. Next, we have Profile. Profile is a very sophisticated product, and that's the one that it was a bit of a challenge for us because at the time when we did the project, we were not able to engage the vendor directly because this is a commercial product. But we were able to recruit a developer who has worked on the Profile system quite a bit, and we also were able to engage a consulting company who were actually led by a couple of family docs who themselves are Profile users to be able to come up with a Profile version of the EMR toolkit. And the challenge with Profile, of course, and also for that matter with a lot of the EMR products, is that unless you actually can work with the vendor directly to influence the actual database design, to, let's say, add new data elements, such as, let's say, a registry for end-of-life care, unless you can actually add new data elements to it. Short of that, all you can do is sort of work around with the forms and somehow tag on additional data elements that somehow you need to retrieve. So with Profile, that was actually a challenge in that we weren't able to add new data elements directly to the Profile database. So all we could do was sort of create our own template and have some of these data elements embedded in them. And these are the forms, the templates that we were able to create. And again, the screen here shows you some examples of the care plan and the family and grieving documents that we have, and also some of the symptom management tools. And if you look at one of these screens, let's say on the home screen on the top left, you'll see, in fact, right next to the home tab, it's a little small, you can see care plans, documents, family grief, pain, nausea, constipation. So there are all these different tabs, and each one would be a particular template that we have developed as part of the end-of-life care practice suite. just to mention that with the profile, towards the end of the project, Profile released a dashboard feature that would allow the generation of reports, which would be a very nice piece to go with the quality indicators. But with Profile, we were not able to make use of all the quality indicators. In fact, across all the 3 EMR products, we've only had limited success in terms of incorporating those quality indicators as reports, because again, not being able to get at the data elements directly, somewhat limited our ability to add new elements which would be needed in the reports. So that was Profile, and the next one is MedAccess. With MedAccess, we were quite fortunate because of Bruce Hobson, who's one of the family docs. He's also a whiz in terms of computer programming, so he was one who actually developed all these templates for the MedAccess product. And it so happened that Bruce Hobson was also heavily involved and continues to be heavily involved with the practice support program, and also PITO, which was the Physician Information Technology Office at the time, who was responsible for the EMR deployment and support. So he was very much in there in terms of right in the front line, knowing what's needed in terms of the tools and how to go about influencing the change. So with MedAccess, these are examples of the screens that he has developed, and as you can see on the lower right corner, he's also managed to generate some reports for the indicators. So MedAccess, in fact, is the one that we have had some success in terms of incorporating indicator reports directly. Whereas, let's say with Oscar, all we could provide would be a set of queries that the user would then have to cut and paste to then generate the actual report. But with MedAccess, you can actually click the button and you can actually get the report directly. So those are the 3 EMR products that we were able to develop the actual tool. Next, I would like to talk about the distribution methods, because once you have developed these tools as templates and forms and whatnot, you need to find a way to get the tools out there, because the providers out in the field, in the primary care, in their office and clinics, would be already using some versions of the tools of the EMR products. So in fact, that was also one of the challenges in that, well, how do we know which versions these users are using with respect to the EMR products? Because they could be using different versions. Fortunately, in BC, we're moving towards the environment whereby we're using sort of more or less sort of an ASP type of model, whereby multiple providers would actually be using a single instance of the EMR product. So in that sense, it's not as if everyone has their own local version of the EMR. So we're moving towards sort of having single instance share among a number of providers. So in that sense, that was very much to our advantage. So what we did in terms of the distribution then was that we experimented with a web-based distribution method, because we wanted this to be as easy as possible without having to require programmers and also the vendor direct involvement. It would be nice if somehow we were able to allow the users, maybe with some of their local help, local tech support, to be able to download these tools and then install them and start using them. So we created a set of web pages, which is what you're seeing here, in terms of a set of tools that you can download on your own. So as you can see on the top there, there's the MedAccess, Oscar, and Profile link on top that you can see. So there's on this page, there's a general introduction with respect to the end-of-life module, the toolkit. And then the next page that you see is an example of the Oscar page, because for each EMR product, you need to have a different set of screens, because you would be downloading different tools, each one being specific to one product. So this one happens to be the Oscar. So it goes through some of the key features, and in terms of some of the ways that you need to think about the updates, etc. And then there's also some video clips that would allow you to look at some of the features and some of the steps that you would need. in terms of downloading. So here's some more screenshots in that there's a download and install videos that would allow you to walk through them, and also PDF files to help you in terms of downloading and installing them. And then there's also a set of tutorials presented as some scenarios, video clip scenarios in terms of what to do. And these scenarios are really trying to aim at sort of helping the provider look at sort of the different transitional stages, the 5 different transitions about the initial visit, follow-up, etc. So next I'm going to go into the summary of results. I've just sort of laid them all out here. We have quite a bit of results that we don't have enough time to talk about them all, so I just sort of selected some of them here. Now, we only had about, in reality, even though it's a 3-year project, it wasn't until the last 5 months or so that we were able to get the EMR tools ready for distribution. So in essence, we only had about 4 or 5 months, and unfortunately it was over the summer, from about the April-May timeframe to the middle of August, where we are actually trying to start promoting it. And as you know, in the summer, it's a very difficult time period because people are away on holidays, and it was very difficult to try to get anything done. During that period then, we have had about 65 different downloads because we track all the downloads. When you go to the website, we actually ask you to register, and then you can download. And the registration was merely just a way for us to track it so that we can contact you to get some feedback in terms of what you think about the module, and also in terms of any updates. There are 38 of them. There were for OSCAR, mid-access, we had 16, and profile we had 11. The reason you see that sort of a declining number was because OSCAR was the first one out the gate. We had it literally out in about March, April timeframe. Mid-access, we didn't actually get it out until about May or so, and with profile, that was the last one out the gate, which was around June, July timeframe. So as you can see, the longer you have it out there, the better chance you have with more downloads. So that was one thing. A couple of other pieces of results here is that we worked quite closely through the help of Bruce Hobson to work with the mid-access vendor, in that now the tools, I'm happy to report, all the templates that Bruce has developed, they're now part of the provincial mid-access toolkit, the library. So users now can actually, as they get their access EMR product, they would actually be getting those templates. And there's a provincial library that they can go to the vendor's site to actually get at those templates, the EMR end-of-life care tool templates. With OSCAR, they're now in the OSCAR eForm library for all users. So again, if you're an OSCAR user, you can actually go to the eForm library, and then those templates that you saw earlier would be there. With profile, we are still sort of relying on our website from the project for the users to download the tools. And as I indicated, there's a dashboard that Profile released last summer. And there's a couple of the indicators that we were able to incorporate into that dashboard. But right now, we're still having to rely on the project website if you're a Profile user and you want to download those Profile end-of-life care tools. Aside from that, we were able to get some feedback from 23 different participants who downloaded the tools, and we had 2 rounds of feedback on the EMR tools over different time periods. And we found that most of the tools that were most used, I should say, were around the assessment tools, symptoms assessment, in particular symptom management, and also the registry, and also some of the guidelines, so some of the documents around the guidelines, and also the advanced care plans. And these were the tools, at least the participants were saying, yeah, they used them. The other tools, they were used to much less extent, such as family grievance, etc. They're used to a much lesser extent. just give you a couple of participant comments. Now remember, this was sort of early days when we captured the comments. So one here says, I believe it's very thorough and I look forward to using it as I anticipated. Will trigger standards of care reminders. Next comment was, I find it resourceful for the PPS algorithm handouts, and it's nice to have all these algorithms to be in the same spot and not having to search for all the forms. So there seemed to be some positive feedback, and we've also had some feedback with respect to the usability of some of the tool features that we would like to incorporate into the next version. In terms of some of the lessons learned, well, what we found out was that the providers and provider organizations, for instance, let's say the practice support program, they're very much wanting to adopt the end-of-life care tools into the EMRs. Everyone we talk to, they said, yes, it's almost a no-brainer. But the reality is that they're all sort of have time constraints, and they're all the competing priorities and demands. So it's very difficult for them to engage. Okay, because we've actually held some dissemination sessions, and some of the providers were able to attend the sessions, but we would have loved to have more. If you consider that the end-of-life module, over its couple of years of being offered by the practice support program, I think they've had over maybe about 1,500 to maybe about 1,500 providers who have actually taken the end-of-life module, okay, and offered by PSP. So we would love to have all of them being involved to download the end-of-life care toolkit for their EMRs. So that's one thing. Next was that there was a lack of vendor attention, and that have led to inconsistent documentation and our inability to identify end-of-life patients. Because in all fairness to the vendors, most of these vendors, they're quite busy in terms of addressing all the user needs and requirements with respect to enhancing the use of EMRs. And a lot of them have to deal with very high priority items and most common issues. And even though end-of-life care is an important issue, as we all know, but when it gets out to the GP community, most GP may see about 3, 5, maybe 10 patients who are at risk of dying or at end of life. So unfortunately, it's not a high priority item, because when you take into account all these things that the vendors have to do, the end of life care is typically not on their radar screen. And what happens then is that led to inconsistent documentation among the providers, because they have to somehow incorporate end-of-life care, the documentation for end-of-life care, into existing EMR functions. And typically that's scattered all over the place. And as a result, you can't identify these patients easily. So next is the need to standardize end-of-life care documentation. And I think, again, that's not a surprise to anyone, in the sense that we do need to standardize the documentation. In fact, some would argue that generally EMR products need standardization in terms of documenting different types of care, especially with chronic illnesses, because some of you would know from the frontline experience that often the documentation is quite inconsistent. Now, what's interesting is that with respect to the end-of-life care documentation, there are some suggestions that we need to harmonize it with the chronic care documentation to reduce provider cognitive overload, because we can't have end-of-life care documentation being so specialized, so unique out there, that it's totally separate from the way that the chronic disease management documentation is being done. It needs to be synchronized, harmonized with that, because in some ways, some are recognizing that end-of-life care really now is becoming sort of almost a form of chronic care management as the patient moves towards sort of these transition stages. So that need to be harmonized. Next, the lessons learned was that in order to be successful, we really need to align with provider organizations who are responsible for large-scale change to adopt, scale up, and sustain EMR-supported end-of-life care. So as you recall, our objective was to really try to integrate the palliative approach into the existing primary care setting and try to see if the tools can be adopted, and more importantly, we need to see whether we can measure it and scale it up and then make it sustainable. In order for that to do just that, a 3-year project is nowhere near sufficient to make it happen. What you really need would be the alignment and partnership with provider organizations such as the GPSC, the General Practice Service Committee, and also the Practice Support Program and the Doctors of BC, and also Division of Family Practices. These are the provider-driven provider support organizations that would take the leadership and partnership to be able to make it happen. And they have their own priorities and their own strategies in terms of what to do next. So you need to align with them. And if you're out of sync with them, then things just don't happen. And the last bullet here would be that in terms of running KT projects, we need to have realistic time frame and funding provision. Here we thought the 3-year project, well, we should be able to do it in 3 years because we already have the best practice. It's really a matter of incorporating them into EMRs and then disseminating them to improve the uptake. While we were grossly underestimating the time required, because 3 years is not nearly enough, especially when you need to align with what's happening within the province, with all the jurisdictions, with their priorities and their strategies. And the funding then would need to work accordingly, because if you want to deal with large-scale KT projects, you know, here we want to try to distribute the end-of-life care tools and EMRs throughout the province of BC. 3 years is not enough. So here are some of the next steps. And again, there's a whole bunch of other next steps, and some are suggestions only. Here they are. One is that I think it's good, reassuring to know that even our project finished last August, I have received some inquiries from health regions in terms of they wanting to learn more about these end-of-life care tools in the EMR products. They want to see how they can access them, how to use them, and most importantly, who's supporting these end-of-life care tools within the EMRs. The unfortunate thing is that our project was ended last August, so we don't really have any ongoing support at all. But the next point will hopefully be a little bit more reassuring, in that the next bullet says the GPSC Practice Support Program has agreed to develop the content and EMR for end-of-life care in 2016-2017 work plan. Now, when I learned from Bruce Hobson and Doris Barwick earlier, they have had ongoing conversations with the General Practice Service Committee Practice Support Program in terms of taking on the end-of-life care tools. But last year, we already approached them, but they had the hands full. They had all these learning modules, all these chronic disease management modules that they need to work on. But this year, as they're developing their 2016-17 work plan, looks like we may have the opportunity to incorporate the end-of-life care tools as part of the EMRs. So in fact, Bruce told me recently that they're now looking at collating all the requests around the end-of-life care tools in terms of being able to incorporate them into the EMR for next sort of update. An example of that would be Neil brought to our attention, Neil Hilliard, the palliative care specialist, brought to our attention that there's a new version of the BC Palliative Care Benefits Program registration form. Well, that needs to be incorporated in it, because last thing you want would be links to forms that are outdated or dead links. So what we would really like to see as some of the next steps would be that when the EMR tools are ready, to update the provider. So if the PSP, for instance, would be able to update the EMR tools to incorporate the end-of-life care tools, then what we would like to do is to really update the providers on the PSP end-of-life module. For those who have taken the end-of-life module but have not used the EMR tools, or have not used the module knowledge itself in their practice. So we're really trying to look at those providers. Remember I said earlier, you know, the end-of-life module has been going on for a couple of years, and they train I believe around 1,500, maybe up to 2,000 providers on the end-of-life module itself. And even if we just look at that particular group to now be able to give them the updated end-of-life care toolkits within the EMR tools, then that would have been a huge success. And as I indicated earlier, we need to align with provider organizations. So I think, doctors of BC and in particular divisions of family practice, there's about 32 of them within the province of BC. They're the ones on the front line organizing, helping, working with the providers within different communities on quality improvement initiatives. And some of those quality improvement initiatives happen to be around EMRs. And if we can align them with those who are working on the EMR tools to look at end-of-life care tools, then we can really leverage each other's effort to amplify this degree of success. Now, here's my pitch in terms of the evaluation, in that because of my strong interest in evaluation, I really would like to encourage us to be able to evaluate this effort with respect to return on value, because nowadays everybody's asking about return on the investment, return on value, etc. What I would suggest maybe is to apply the RE-AIM framework. This is the framework that looks at the reach, efficacy, adoption, implementation, and maintenance. And here's just a slide that shows you the overall framework. I know it's a very busy slide, and I'm not going to go into detail, but all I want to draw your attention to is that these are the different dimensions that would allow you to measure quantitatively with respect to your knowledge translation effort. What's the uptake, in terms of, again, boils back down to the denominator and numerator. How many people were you able to spread it out to, how many people actually adopted it, and then how many people actually were able to use it in their practice, etc., etc. So this particular framework was published in the Suzanne Balkin's 2009 paper. So I just thought I'd show this to you so you have an idea about that. And that was actually my last slide, and this is a list of the references, and I believe the slide deck will be made available afterwards. And last, I just want to acknowledge the funding that we received by the Canadian Frailty Network, formerly known as the Tech Value Net. So this is where I will stop and pass it back to the moderator.
Thank you, Francis, for your comprehensive presentation. And I know we've gone a little bit over our time, but I think we still have some time for some questions from our webinar audience today. Even though the presentation was very comprehensive and provided a lot of information. And I guess one of the first questions that came up was, and seeing the tools, you did have chronic care harmonized in there, is were the tools originally designed for cancer diagnosis, or can they be used for all patients nearing end of life?
Thank you for that question. It is really for all types of end-of-life care patients, because it was not for cancer to begin with.
Okay. That's another really good question came up about what would be your advice for highly qualified personnel on doing KT projects?
I think this would take the kind of individual that has a lot of ability for lateral thinking and be able to work with individuals. It's one of those things where you need to always be able to see the big picture of where you want to get to 3-5 years from now, but at the same time, very much on the ground, being able to grind through all the logistical details and all the bureaucracies and all that. So, because half of our project really was working with all the different organizations on a regular basis in terms of working with them, convincing them of the importance of this project, and people know me by now. I don't take no for an answer. I just sort of keep going at it until they either run away when they hear my name, or they just sort of say, okay, we'll do it. I'll stop there.
That's good. I guess one of the other things is, how are you planning on embedding these findings in, I guess, what would be termed the real world? What's your knowledge translation strategies to inform the decision makers and the EMR tool makers, and not maybe just concentrating on journal publication, webinars, and conferences?
Excellent question. As you may recall, the last slide about the next steps, The nice thing is that our project team members, in terms of the co-investigators, like Doris, Neil, Bruce, and Morgan, they're all practicing physicians. And so they are the ones who are actually promoting it, and through the help of the GPSC, the General Practice Service Committee, and the practice support programs, they're now the ones who are actually trying to advocate and take it to the next level. Because now that we've got some experience in terms of how this potentially can be done, now we need to scale it up in terms of fine-tuning the tools, getting it out there, and most importantly, making it sustainable. And my pitch about the evaluation is very much getting at, here we're spending all this time and effort. How do we know it's making any difference? I know GPSC, through the practice support program, does do ongoing evaluation. And what I would like to suggest is that if you incorporate the tools directly in EMRs and have the ability to do queries and reports, then you can actually make it very objective and based on quantifiable results, going beyond surveys. So hopefully that will be the next step. I don't know whether that helps or not. I'll stop there.
Okay. I didn't receive any further questions on that, but with regard to the content, is there collaboration with Pallium Canada regarding the LEAP program and the content provided by Canadian Virtual Hospice?
I think at the I think the short answer is no. We didn't work actively with Pallium. At least I don't recall. My co-investigators on the call, they may correct me on that one. I mean, we did let people know about the project. So Virtual Hospice, they're aware of our project. In fact, initially with Virtual Hospice, we wanted to see whether they would be able to help us mount the web-based distribution method. But at the time when we met with them, I don't think they were able to provide the degree of support that we had hoped for. So in that sense, we weren't able to work with them at that time. And furthermore, our focus at the time was really around the BC environment. And within BC, there were a lot of activities within the end-of-life care community in terms of trying to advocate the practice. So I guess you can say we were a little bit more BC focused at that time. I'll stop there.
Okay. One of the issues with these tools is the identification of the population that these tools would be applied to. For cancer, it is easier. Could you see applying other identifications algorithms such as frailty screening to identify other populations that may be suitable for these tools?
Well, that's a great question. If you recall, one of our stages, the stage 5, the last stage, was to do with looking at identifying the extent of end-of-life care documentation. So in that particular sort of sub-project, we engage in 4 different networks. The CFN, Canadian Primary Care Sentinel Surveillance Network, and the BC network, in terms of trying to get them together to look at EMR products. How they can identify end-of-life care patients, such as frailty, and also organ failure, etc., from their existing EMRs. So we have had some degree of success. We didn't use the Canadian Frailty Framework explicitly, but because we were looking at existing data, but we were able to try to identify the different elements in terms of how to go about identifying that. I didn't present that work today. But for instance, one of the group, in terms of looking at the frailty patients, we were able to identify a whole bunch of different data elements that may be indicative of frailty patients. And I think that work was actually done by, in fact, the Nova Scotia group, the MARNET. And in fact, MARNET, along with a bunch of other investigators, have sort of taken on the next step of this knowledge translation project. They have a current project that is looking at patient identification algorithms, and I'm sure frailty is one big piece of that. So they're taking that on now. So Fred Burge and a number of investigators are very much taking that on. I'll stop there.
Okay, and I know the project you're talking about. I guess we're just about getting close to completion. We have a few more questions, but I think the last question should be basically any plans to continue this work?
The plan basically then would be in the hands of the GPSC practice support program and the investigators who were originally involved with this knowledge translation project, you know, namely Doris and Neil and Bruce and Morgan, and also some of the providers that we worked with at the time. It's really, they have to own it. So hopefully that's what's going to happen next. I'll stop there.
Okay. And there are a few further questions, and I guess we had talked earlier if that anyone was interested, we would send your email so that they could contact you directly. And
Yep.
You said you're okay with that.
Yes, I'm happy to take on any questions, or if I can be of any help, please by all means contact me.
And I don't recall, is your email on your slides? I don't remember seeing it.
Probably not. Sorry, my oversight.
That's okay. And like I said, we will be putting those slides up, and we'll see if we could add your email there because there's still another 5 or 6 questions and we're running out of time. So thank you very much, and I'll send this to John for some final remarks.
Thank you.
So thank you, Francis, for the excellent talk. There is a webinar satisfaction survey that will pop up on your screens within the next few seconds. Please take some time to provide us feedback, and we do take the feedback seriously, and we do use it to improve the webinar series. There are 3 upcoming webinars that are scheduled. They're listed on the screen. So the first upcoming one is April 20th, and that looks at the evaluation of integrated clinicians, electronic tools, and practice support systems to complete acute care quality of life assessments of frail older adults. The one on May 4th, it looks at frailty measures for persons with intellectual and developmental disabilities. That's a knowledge synthesis grant that Canadian Frailty Network funded. And the third one that's upcoming is on Wednesday, May 18th, and that looks at a pilot study of electronic commerce mobile mobile device to improve physical transfers of nursing home residents. As we said before, the webinar slides will be available on the website, and the address for that is on the screen. So thank you all for attending and on behalf of the Canadian Frailty Network. We are thrilled with the level of attendance that these webinars generate, and look forward to interacting with you on our next webinar on April 20th. And with that, we'll close this webinar. Thank you again.